All right. Hello, hello. Welcome, welcome. Ooh, look at all these people coming in. Welcome, everyone. Feel free to hop in the chat. Let us know where you're joining us from. All right. Okay. Just going to give it a few more seconds. And in the chat, make sure that you're choosing the selection everyone. Otherwise, it'll just be going to us, the host and panelists. So feel free to write in where you are coming in from and make sure you're selecting everyone. Wow, California. Oh, New York City, Kansas. Awesome, awesome. All right. Hey, Queens. All right. Okay, everyone, we're going to go ahead and get started. So, welcome everyone to the webinar, How Vaginal Estrogen Therapy Can Reduce Risk of UTIs. I'm Megan Claire Chase, the Breast Cancer Program Director here at SHARE. Now, before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, our support groups, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during the presentation, but feel free to engage with each other in the chat. Once our fabulous speaker finishes presenting, we'll begin the Q&A discussion. So feel free to ask your questions through the Q&A section at the bottom of your screen. And remember that our presenter, Dr. Rubin, is unable to give specific medical advice. So please keep your questions general in nature. And we also have closed captioning available. You can enable this feature by clicking the live transcript button on the button on the bottom of the screen, say that quickly, and selecting the subtitle option. And also, this webinar is being recorded, and we'll share the recording in a few weeks with all of the registrants, and it will also be added to our website. So now, I'd like to hand it over to Dr. Rubin to introduce herself. The screen is yours.
Hi, y'all. Do you hear me okay? I am so honored to be here. I am just so grateful for the invitation. I'm a big believer that patient advocacy organizations change the entire world. And it has happened. I've seen it happen. And I continue to show up where I'm asked because I believe that you give people a little bit of knowledge and education, they make really great decisions with their life and with their bodies. And we need more research, we need more funding, and we need to get loud. So I'm Dr. Rachel Rubin. I am a urologist, and I did my fellowship training in something called sexual medicine. And so I take care of all genders, and I do 4 things. I deal with issues of libido, arousal, orgasm, and pain. And there is a lot of issues and overlap within the cancer community. And so I see a lot of cancer patients, whether it is prostate or breast or any gynecologic cancer or colorectal cancer. And really what I do is I give a crap about how it affects the quality of your life. Right. And it turns out that the whole goal is not just to keep you alive for a really long time, but the goal is to keep you living. And if I don't get to know you, if I don't know and care about, and find out what you want out of your life, I can't help you achieve those goals. And so we can go ahead and remove the screen for a second. I want to just go perfect. I want to not share slides for a second. So I'm really excited to answer all of your questions. I would love for everyone to go to the chat and go to the Q&A and make sure you talk to me, that you ask me questions. It is not often that you get time with a doctor to talk about quality of life issues. And these are issues that y'all are talking about in your support groups, you're talking about in your chat groups. And the problem is we have a problem with private parts, right? Is we were taught that they're private, that we're not supposed to talk about private parts. And we have cancer, so we're not supposed to talk about our clitoris. We're not supposed to talk about our orgasm. And God forbid we say the word vaginal dryness. And so I'm a big believer that the term vaginal dryness is actually killing people. Okay? Vaginal dryness is killing people. Now stick with me for a second. The reason I believe vaginal dryness is killing people is because, one, nobody wants to talk about vaginal dryness with their oncologist. Gosh, you're getting chemotherapy. The last thing you want to do is mention vaginal dryness. Well, the term vaginal dryness is horrible because it's not really what's happening. Yes, things are dry, but it's also free. You get urinary frequency and urgency. You leak urine when you cough, laugh, and sneeze. It hurts to wear pants. It doesn't just hurt to have sex. For some people that is so far away from their interest, it hurts just to sit. They can't get through a car ride without having to get up and use the bathroom all the time. This is actually not just a little vaginal dryness. And so the terminology is killing people, because if we just call it a little vaginal dryness, we say, oh, come on, you just suck it up, right? Just use a little moisturizer, a little lubricant, you'll be fine. But the problem is remember, it's not just vaginal dryness, it's urinary tract infections. And urinary tract infections can kill you, okay? And do kill women and men quite a lot, actually. Quite a lot of our healthcare is spent on people dying of urinary tract infections. And we know that the bladder, that the vulva, that the vagina, the urethra are very hormone sensitive structures. And so the problem is when you take away someone's hormones completely, and there are reasons, and we're going to get through it and talk about cancer and estrogen-based cancers and things like that. But the benefits of supporting the tissue, keeping it healthy, keeping it acidic so it can fight infection, and often the only thing that has proven to do that and that is successful are vaginal hormones. And so it's really important that we understand that this actually isn't just a little vaginal dryness. This isn't just a little problem that can be made better all the time with just a little lubricant. Oftentimes, we really do have to fix the underlying problem. And the most important thing is you deserve that. You deserve to sit without pain. You deserve to make it through the night sleeping, without urinating. You deserve to not get urinary tract infections, which can kill you, right? And so we make lots of decisions in our cancer treatment strategies. Your doctors are always talking to you about risks and benefits. For goodness sake, many of you have taken poison, chemotherapy, to try to kill the cancer cells in your body. And as we know, there is horrible unintended consequences of that, right? So we're always putting up with risk. The problem is we undersell the benefits, right, of using something like a vaginal hormone, which have enormous benefit of preventing urinary tract infections, fixing your urinary problems, making sex not painful, right? It has this amazing benefit. And actually, the data doesn't show significant risk. And so because of the terminology and the words, vaginal dryness, the terms estrogen, right? Everyone's doesn't want to talk about it. They not only don't want to talk about it, but they don't even want to hear about it. They don't want to give you the options that actually there's lots of data that shows safety, that show that not only is it safe, but it really works. And so if we can't say vaginal dryness, if we can't talk about our vaginas or our bladders to our doctors, we suffer. You suffer in silence. And it's really, you can't post about it on your Instagram page. You can't post about it on Facebook. So I hope that that helps. And I'm gonna share my screen with you in just a second and show you a few slides. Hopefully you can see. I'm gonna just put the chat up there so I can see. And so we're gonna talk about the data and what we know today. I'm gonna try to keep it short because I really do want to spend time answering all your questions. Because here's the deal: it doesn't matter what I want you to do. It doesn't matter what I think you should do. It matters what you actually choose to do and how you feel about it and how you feel about your decisions. Because at the end of the day, we don't know everything about medicine. And at the end of the day, we make the best decisions that we can. On September 6th, one day before my birthday's tomorrow, we make the best decisions that we can on September 6th, 2023. But we have to demand more data. We have to scream and yell and get loud. We cannot keep telling cancer patients, ooh, it's better to be safe than sorry. You shouldn't use vaginal hormones when we know vaginal hormones are safe. Okay. We have to stop telling people, well, there's just not enough data for that. We need to demand that there be more data. And so we have to get loud. We have to understand that this isn't just a little vaginal dryness. So for any of you who follow me on social media, thank you. If you don't, I encourage you to follow me at Dr. Rachel Rubin or sign up for our newsletter at rachelrubinmd.com, because not because I want more followers, but because I'm constantly yelling and screaming and advocating for better quality of life and sexual health and really what the data, evidence-based data, what it actually shows. So I want to say, anyone in the chat box know what this is? Somebody's going to be brave and tell me what this is in the chat box. Do you know what this is? I'm going to wait. Let's see if anyone's brave. Oh, they don't know. You got it, Denise. And Darlene, you are awesome. This is Viagra. Oh, Bonnie's got it too. This is Viagra. Viagra was created in 1998. And Viagra is a miracle drug. I do a lot of male sexual health. I love men's sexual health. I love treating men's sexual health. I love treating women's sexual health. Viagra is a muscle relaxer. It relaxes the penis so that it fills with blood, it arouses, and it gets hard. Okay. Viagra changed the game in 1998, but Viagra actually and Cialis, they can actually help with urinary symptoms. They can, if you take a small dose of Cialis every day, it can help with urinary symptoms. We often give it to male patients. So here you have a drug that improves sexual health. It improves urination. Okay. That's a pretty good drug, right? That's a bajillion-dollar drug. Well, what if I told you that female Viagra has been around long since before regular Viagra in 1998. In fact, female Viagra has been around since the 1970s. We have a drug that not only improves sexual health, but it improves urination, and it's actually 10 million times better than Viagra because it prevents urinary tract infections by more than half. I'm serious. We have female Viagra. It's been around since the 1970s in different forms, and it's called vaginal hormones, vaginal estrogen, vaginal DHEA. It improves sexual health. It improves urinary symptoms. It helps with pelvic pain, makes sex comfortable, and it prevents urinary tract infections by more than half. And yet, why don't we yell and scream about it? Well, why do you think? Why don't you know this? Maybe a lot of you do know this, which is so fabulous, but you showed up to this webinar because you wanted to hear about it. And it's a big problem. We don't talk about women's sexual health the way we talk about men's sexual health. And we don't advocate for women's urinary symptoms or women's sexual health issues. But you'd think urinary tract infections would be a big selling point. But because it's the word vagina, we can't get people to care about this. It is, there's no catch. I'm not fooling. I'm not presenting data that exists. It is just how badly we take care of women in this country. And so menopause is the worst PR campaign in the history of the universe. Everyone thinks, oh, menopause, I went through that years ago. It's just hot flashes and night sweats. That is just not true. Once menopause happens, it never gets better, right? You're always in a menopausal state, and you live about half your life often in that menopause state. And the lack of hormones affects every cell in your body, your brain, your heart, your bones, your vagina, your bladder. It changes everything, right? Think of like a plant that needs water. right? So the bladder tissue needs water or hormones in order to thrive, to be strong, to be healthy, and to fight infection. Without the hormones, it gets thin, it gets raw, it gets irritated, and urinary tract infections can happen. Now, this happens for some people even before the hot flashes and the night sweats and the period stopping. I have patients in their 30s who have these symptoms, but for some people, it actually happens much later. It can happen in their 60s or 70s. The vaginal and genital, the urinary and genital symptoms, they can happen and they never get better because the tissue is starving for the hormonal support that it needs, right? Wrinkles are the lack of estrogen and the collagen in your face, but the vagina loses the hormones, which is what keep it acidic and strong to help it fight infection. And this just gets worse and worse and worse over time. And again, it's all about anatomy. I believe when you give people information about how their bodies work, they can make excellent choices and decision of what they do with their healthcare. And so when you understand anatomy, then you understand that we all start from the same place. Everyone starts the same. You develop a penis or a vulva, depending on the chromosomes that you have in your body and your hormones. If anyone has changed the diaper of a baby girl, baby girls do not have the same genitals as grown-up women, and you change your genitals in menopause because it's a hormonal thing. So babies have no hormones. Then you go through puberty and you grow labia, you get an opening that is lubricated and sex can happen. Then after menopause, the tissue doesn't have hormones anymore, so it kind of goes in reverse. So things kind of shrink up. They can get raw, they can get irritated, they can get thin, and then you can develop urinary tract infection. And if you take biopsies of this tissue, it shows estrogen receptors and testosterone receptors. And without those receptors having the hormones, the tissue gets thin, it gets raw, it gets irritated. And so what are the symptoms? My friends, this is not just a little vaginal dryness. It's not. It's decreased lubrication. It's pain with sex. It's bleeding after sex. It's a decrease in your arousal, your orgasm, your interest levels. It's, gosh, I have never noticed my vulva before, and now it's driving me crazy. I can't wear those yoga pants anymore. You get irritation, burning, and itching. It's pain with urination. I think I have a UTI, but all the cultures are negative. Or I do have a UTI, and I'm getting them 3 times a month, and I cannot stop them. It's urinary frequency and urgency. In fact, the pH of the vagina should be acidic so it can fight infection and have a healthy microbiome. But without hormones locally, the vaginal pH gets upwards of 7.5. And so the bad bacteria start to grow, and the healthy bacteria, the lactobacilli, cannot grow. And unfortunately, no probiotic on earth has been shown to fix this problem. But vaginal hormones do fix this problem. And so we can see genitourinary syndrome of menopause, which is what this is called. It's not just a little vaginal dryness. The new terminology is what we call GSM. So everyone at their computers yell GSM. I know you're on mute, but say it loudly. GSM. Genitourinary syndrome of menopause. Okay. This is why things are so uncomfortable. This is, thank you, Megan, loud for everyone in the back to hear. This is why it hurts to wear the yoga pants. This is why you're getting up all night to pee. It is GSM, the genitourinary syndrome of menopause. And so you have to understand that this is a huge quality of life issue, but this is a life and death issue as well. And I don't know about y'all, but I don't put my hand on a hot stove ever, right? Why don't I put my hand on a hot stove? Because my body will pull away, right? Even if I say, ooh, I like my hot stove. I want to be intimate with I want to touch that hot stove. Your body's going to pull away. The muscles are going to say, no, there's a fire there. And underneath this tissue, which is raw and irritated and painful, almost looks like a sunburn, your pelvic floor muscles are trying to protect you. So if you say to yourself, I'd love to be intimate with my partner. I've had this awful diagnosis. My partner's been so supportive. I would like to be intimate, but it feels like raw sandpaper burning hot fire when anybody touches you. Your muscles don't care how much you love your partner. Your muscles are there to protect you and keep you safe, and they know it's going to hurt. And so these pelvic floor muscles get in all sorts of tight spasms, and they will not relax when they're in pain, no matter how much your brain says, just chill out, just relax. It's okay. You're safe. It's not going to work. So we see what's called pelvic floor dysfunction very frequently when you have genitourinary syndrome of menopause, or GSM. So y'all, this is crazy. I do this crazy thing in my office with my patients. I give everyone a hand mirror, and if they're comfortable, which I really encourage them to be comfortable, and everyone gets a tour of their vulva and vaginal tissue. They get an anatomy lesson. They get told, this is your labia majora. This is your labia minora. This is your clitoris. Look, we can see the GSM with our eyeballs. I give you a whole lesson. I do that. And because of that, I was on a full page in the New York Times in the science section, because that's apparently a novel thing, is to show women their own body parts. It's pretty embarrassing if it weren't true. I mean, it is pretty, I was happy to get the press, but this is a picture of us doing the exam with a patient who was learning about her GSM, right? And we were giving her a tour of the area. And so it's really important that you're going to get out your mirrors and look at the tissue for yourself. Using a vaginal hormone, you can decrease urinary tract infections by more than half. This data has been around since the 90s, if not before. There was a huge paper in the New England Journal of Medicine in the 90s. Why didn't it get disseminated? Why didn't they do more? Because we can't say the word vagina. I don't know why. It's just a disaster. Here's a paper that was just published in May of this year, which showed in the Kaiser system, 5,600 patients were looked at, and they decreased women who used vaginal estrogen, decrease their risk of urinary tract infections by more than half. This is my data, which shows that if you use vaginal DHEA in thousands and thousands and thousands of patients, you will decrease urinary tract infections by an enormous amount. Look at this. This is over 75. They went from 31% had urinary tract infections down to 16%. It's just wild how much we can reduce the risk of urinary tract infections. And so we're going to get to the cancer fears. I'm going to show you some data, but let me just show you what this looks like. So it can look a few different ways. So there are creams that you can put inside the vaginal canal, and we recommend putting about 1 gram of the cream every day for 2 weeks and then twice a week. You can get a tube of this cream for $20 on either using a GoodRx coupon when your doctor sends a prescription, or through Mark Cuban's online pharmacy when your doctor sends a prescription. $20 for this tube, which lasts about 2.5 months, $20 per tube. So you can treat GSM for less than $10 per month. When I got out of my training, which I do have a lot of gray hair, my friends, but it wasn't that long ago, it was $500 a tube. It's now $20 a tube. It's because of our yelling, our advocacy, and our screaming, we've gotten it down to $20 a tube. Now, one trick I like is people don't always love creams. They're kind of messy, they're goopy, they're gloppy. Sometimes you can rub it in so it's not as messy. It's a good workaround. But many insurance companies will cover the estrogen inserts, which is 10 micrograms. So I'm going to show you some data to show that this isn't a whole body hormone therapy. 10 micrograms. If I were to give somebody an oral estrogen pill for menopause, I would give 2 milligrams. This is 10 micrograms. So this is like a gajillion times less, right? Micrograms to milligrams. It is like minuscule doses that would do nothing for hot flashes. It wouldn't protect the bones. It doesn't do anything. It doesn't go through your bloodstream. It stays local and fix the local environment. It's pretty amazing. So you can use this pill every day for 2 weeks and then twice a week. It's one of my, I love that option. Another great option is often expensive, but sometimes insurance, if you fight, they can cover it. It's a ring that you set it and forget it. You put it in the vagina for 3 months, and it gives a minuscule dose of very localized estrogen every single day. Again, not enough to go through your bloodstream. Another therapy, which I love, is actually not estrogen at all. This is the data I just showed you to show that this data here, that you can decrease urinary tract infections by more than half, not using estrogen, but a product called DHEA. Now, DHEA is a precursor hormone. You can go to the supplement store and get some DHEA, but this is an FDA-approved option where when you put it in the vagina, your body's own enzymes kind of make it into a local amount of estrogen and testosterone to heal the tissue. And it is a lovely suppository that's got palm oil and DHEA, and you put it in every night at bedtime. And it lowers your pH and it helps your microbiome. And now we have data to prove that it prevents urinary tract infections. So, some non-hormonal therapies, right, is moisturizers, lubricants, vibrators, pelvic floor physical therapy. These are all things that I'm sure we're going to talk about in the Q&A that I would love to talk about, but none of these prevent urinary tract infections. So I love Band-Aids. I love making sex more comfortable. I love making it more fun. I love helping with orgasm and pelvic pain, but none of these therapies are shown to necessarily fix the problem, like fix the urinary tract infections. And so I'm a big advocate for vaginal hormones. But cancer, Dr. Rubin, you are talking to a cancer support group. Are you absolutely out of your mind? You said the word estrogen, and I am a cancer survivor with estrogen-sensitive cancer. I love being in this room, and I wish I were in this room in person to hug all of you. And so it is my job to arm you with the knowledge and the data to say, do I have all the data in the world that ever existed? I mean, I've seen it all and I've never seen anything bad, but do we need more data? We do, and I need you to advocate for it. I need you to get loud for it. But let's tell you what we do have. We have a consensus statement from the Menopause Society, the International Society for the Study of Women's Sexual Health, on how to treat GSM in breast cancer patients. It's a lovely document that you can bring with you to your doctor and go through all of the options. I'm not going to go through all of these details, but the idea is when you have terrible symptoms, and to me, terrible symptoms are anything you are bothered by. If you're getting urinary tract infections, if you have frequency and urgency, if you're leaking urine, if you're miserable, if you want sex with your partner and you can't have it, you have terrible GSM and you deserve access to vaginal hormones, which show no increased death rates of any kind with any kind of cancer, which I'm going to show you in just a second. So it's all about shared decision-making. Tamoxifen causes uterine cancer. We use it because it decreases recurrence and we take those risks, yet vaginal hormones have never shown any risk like that, and yet people aren't getting offered it because it's just quality of life issue. It's just a little vaginal dryness. You can suck it up, just deal with it. And that's not acceptable. It's not an acceptable conversation. So, this is a paper that just came out hot off the presses. I've never been prouder. Have you ever had, this is the first time I've had a research paper published with my name is not on it. And I know that our advocacy on social media made this paper happen because I know the medical student who heard us speak and said, I want to do a project. And she wrote this paper that shows that in a very, very large claims database, they looked at 42,000 women with genitourinary syndrome of menopause, and they looked at the patients on vaginal hormones, and there was no increased risk of breast cancer recurrence within 5 years of patients with a personal history of breast cancer who were using vaginal estrogen. So this is awesome, right? Like, is this a perfect study? No, but here, if there was going to be a signal, we would have seen a huge signal here. And so we have more and more data to show the safety of vaginal hormones. So why are they safe? Because they don't go through your bloodstream. So let me give you an example. If you draw my blood right now, depending on where I am in my cycle, my estrogen levels are between 50 and probably 150. Okay. So me, cycling at my low, I'm probably about 50. At my high, I'm about 150. When I was pregnant with my children, my estrogen was 3,000. My husband, who's downstairs or just put my kids to bed, his estrogen is 25. Okay. So when you're in menopause, your estrogen is 0 and goes to the lab only goes to says less than 5. So it's like somewhere less than 5 is essentially 0. So look at this graph. When you use this 10 microgram tiny insert of vaginal hormones for the first 8 hours, you get an estrogen level of 25, which is what my husband's estrogen level is. So it goes, you get enough estrogen that a man has, and then by hour 12, it goes back to less than 5. So every time it is checked after that in your bloodstream, there is no estrogen circulating through your bloodstream. This data was repeated and they looked at it, and none of these estrogen levels even approached 20, which is a male amount of estrogen. It stayed in the menopausal range. In fact, when you use vaginal hormones, you are getting less than 1 milligram per year absorbed in your bloodstream. And remember, if I give you menopause hot flash therapy, it's 2 milligrams a day. This is 1 milligram per year that you are putting in your bloodstream. So then why does the box of vaginal hormones say that if you use this, it's going to cause a stroke, blood clots, heart attacks, dementia, breast cancer? You must use it with progesterone, and Dr. Rubin is trying to kill you. That's what the box says. It actually says Dr. Rubin is trying to kill you. I'm not trying to kill you, and none of the things on this box are true. In fact, this box is based on a birth control pill style of hormones, very high dose synthetic hormones that you take by mouth, which look nothing like vaginal hormones. Not the same product, not the same chemical. It actually has no similarities whatsoever. But the FDA has this very, very weird rule where all the products get the same labeling, even though this isn't true. And so if your doctor even mentions vaginal hormones to you, a breast cancer survivor or a cancer survivor of any kind is going to go home, look at this box and say, hell no, I am not taking this. And so we need your loud voices. We need you to follow us on social media, because we are getting ready to go yell and scream and march at the FDA again, because they've already gone and the FDA wouldn't change it. This was back in 2018. And we cannot take no for an answer. This box is killing women because women see it and they think they're going to get a stroke, blood clots, all of these things, which have never, there's no data of any kind to prove it. In fact, the big scary study that made everyone afraid of hormones, which was wrong at very many levels, that's for another conversation. That study looked at people on vaginal hormones. Oh, wait, hold on. That's this data. That's a different paper. But that study looked at vaginal hormones and showed no increased risk of breast cancer. They looked at women with breast cancer, endometrial cancer, and I believe it had also ovarian cancer, but I can't remember. It said the risk of cardiovascular disease and cancer was not elevated among postmenopausal women using vaginal estrogen. Oh, this is that study, the Women's Health Initiative. So there's no risk of cancer. In fact, women in that study who did use whole body estrogen, which is not what we're talking about today, had a decreased risk of getting and dying from breast cancer. So the estrogen was not like this idea that estrogen causes breast cancer is not one-to-one. It's not black and white, right? So we know there are cancers that are estrogen sensitive, but that doesn't mean your estrogen causes the cancer. It's more complicated than that. We know, gosh, I'm looking at what data did I put on here. This one showed, hold on, this is a good one. This one was the 18 years of the Nurses' Health Study, which showed no increased risk of cardiovascular disease or cancer. This was a history of women with a history of uterine, cervical, and ovarian cancer who used vaginal estrogen and had no increased risk of recurrence, blood clots, and is very safe to use. And so we have to understand, do we have all of the answers? We do not have all of the answers. There is a little bit of data that is emerging that makes oncologists take pause and nervous with aromatase inhibitors, but there's no data to show increased risk of mortality with aromatase inhibitors. And the data on recurrence is pretty piss poor, according to the North American Menopause Society. And so we need more data. We feel very comfortable about women on tamoxifen. I feel very comfortable about women with uterine cancer, ovarian cancer. I feel very comfortable on pretty much all patients. Definitely with a history of blood clots, you can use vaginal hormones. And so we have to get comfortable. There is nobody who I wouldn't give vaginal hormones to, because if you're getting urinary tract infections, if you have pain, if you have pelvic pain and your tissue looks like a raw sunburn, I know that I can fix it and give you an amazing quality of life. And that really, 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 really matters. And so where can you advocate for yourself? Well, if your doctors are not listening to you, you need other doctors. It doesn't mean get rid of your doctors. It means you need other people to help advocate with you. And so I am on both of these lists, but ISWISH is the International Society for the Study of Women's Sexual Health. There's a Find a Provider section. Those are people who are very passionate about women's sexual health care. And then the Menopause Society is anyone is going to really know a lot about menopause, and those are going to be really wonderful people to work with. If you have a provider that you know, we do courses. We teach people how to do this. If you follow me on social media, you will get so sick of hearing me talk about this over and over and over again. And so I'm going to stop there because I want to have time for lots of time for questions. I'm happy to answer all of the questions because I know this can be a very confusing topic. I hope this was helpful. It only matters if you get something out of this. If you think, oh my gosh, Dr. Rubin, this was a waste of my time, it doesn't help anything. And so I really want to get at the question. So I'm going to stop sharing my screen here and hopefully we can get through all these questions. Was that helpful, Megan?
Oh my goodness. I wish I could see everyone's faces as you were talking and then showing the pictures. I mean, I was just like, what? Yeah, so let's get right into it, right? I'm going to take some of the questions that were sent live and then go to the ones that were submitted with registration. Is it safe to use vaginal estrogen more than twice a week if you're still having symptoms?
Yeah, so that's a great question, and we get it a lot. So of course you want to talk to your doctor. The package really looks at, it depends on the type of vaginal estrogen. So if you use a cream, you want to use that twice a week. You probably could get away with 3 times a week. You want to make sure you're using at least a gram of the cream and that it's getting in the vagina. A lot of times my colleagues will say, just take a little pea size and rub it at the opening. It's often not enough to acidify the tissue and fix the GSM. So it really depends how you're using it. If you're using the tablet inserts, 3 times a week is probably fine. The reason we don't want more and to do it too much, because then you run the risk of getting estrogen in your bloodstream, and that can become the problem. Now, if you do have a cream and you're doing it twice, I talk fast, y'all, I'm so sorry. If you do have a cream and you do it twice a week in the vaginal canal, you do 1 gram, you can take a little pea size and rub it at the opening every day. That is safe to do. If you use DHEA, that intrarosa product, that's meant for every night. And oftentimes, if vaginal estrogen is not working, we'll switch them to DHEA, and we can actually fix the problem much better because we add a little testosterone with that DHEA, because DHEA is the precursor. And so if estrogen alone is not doing it, the DHEA can sometimes help. Now, remember, is physical therapy, pelvic floor physical therapy can often fix the problem because your muscles need to learn how to relax. And so it's usually a combo, the medicine and a rehab protocol. Does that make sense?
It does. And that actually leads to another question. When you're saying that physical therapy, what are Kegel exercises? And
yeah, so most people with GSM do not want to do Kegel exercises because you're strengthening. So Kegel exercise is the thing that you feel. So say you're trying to stop yourself from peeing, that feeling, that like lift to like stop your urine stream, that's actually not good for someone whose muscles are really tight because they're in pain. You actually want to learn how to relax your muscles and strengthen them in a different way. And so it's very helpful to see a pelvic floor physical therapist because they teach you how to relax all those muscles.
So we're getting a lot of questions for those who had early stage breast cancer and they're on, AIs, and then those who have metastatic breast cancer. Is this really safe, this vaginal estrogen?
So here's the deal on, again, we need more data, right? I don't have unlimited data. I don't have decades and decades of long-term use in randomized controlled trials. And the fact that we don't have that when this product has been around since the 1970s is absolutely criminal. Like, it's criminal. The fact that your oncologist and ASCO has not demanded and the NIH has not funded billions of dollars of studies to go into this problem is criminal. And so I put that out there of, do we need more data? Of course. Now, the data that we do have there's no home run data to show any danger of vaginal estrogen. There have now been 1 paper that says there is a slight bump in recurrence on aromatase inhibitors, specifically, not tamoxifen, not metastatic disease, specifically on aromatase inhibitors when you use vaginal estrogen. So that is giving someone, and even that data was small, did not increase mortality, and was not a well-done study, and is based on very old data, even before HER2 new status was even a thing. Okay.
Oh, wow.
So it's not good data, right? So there is no robust data to show harm of vaginal hormones. There's tons of data, which I just showed, to show the safety. Okay. And so the key there is, if you are a metastatic breast cancer person who is miserable because you cannot sit, you cannot wear pants, you get up all night to pee and you're not sleeping, you have to do shared decision-making there. You have to advocate for your own quality of life, because the whole point is to keep you living a life worth living.
So true, that quality of life. Let's see. Do you worry about antibiotic and UTIs with C. diff issues?
Yeah, the point is if you don't use these products, right? If you don't use vaginal hormones and you get recurrent UTIs, meaning urinary tract infections all the time, your doctor gives you antibiotics, the antibiotics stop working after a while. So you need stronger antibiotics. Sometimes you need IV antibiotics, and you can develop horrible gut issues, including intestinal infections, which can kill you, right? So urinary tract infections are not just a little quality of life issue. This is a life and death issue. And so, of course, so not doing vaginal hormones can be more dangerous, like by a lot, measurable, than using them. And so that's where it becomes that risk benefit. Like, there is so much risk not using vaginal hormones.
So will vaginal estrogen also help with vaginal atrophy?
Yes. So we used to call GSM vaginal atrophy before we had the term GSM. And I'll tell you, it is not nice to tell women their vaginas are atrophic. It does not sound nice. It is not nice. And it's not just that the tissue atrophies, which it does. It is also that it dries out, that it changes the pH, that it increases frequency and urgency, and increases urinary tract infections. So just telling a woman she's atrophic doesn't really get us anywhere. It makes people feel bad about themselves, but it's true. In menopause, so when you're born, you have no labia minora, those inner wings. You grow them in puberty and you lose them in menopause. Y'all, if penis is shriveled up at age 52, we would have a vaccine, like Pfizer would be all over it. But no one's talking about the fact that labia are shriveling up and disappearing because we're all prim and proper and we don't talk about our labia, but they are disappearing.
Oh my goodness. Well, my gosh. So let's see. Are hyaluronic acid suppositories similar in effectiveness?
So hyaluronic acid suppositories are wonderful. They are Band-Aid like everything else, like any kind of moisturizer. Moisturizers are great. They really help the tissue, just like moisturizing your face. So you can moisturize your face, or you can use a cream that has a retinol that actually helps fix the collagen, right? So it's the difference between a moisturizer and a therapy. So hyaluronic acid, especially if you're an oncologist and you decide that you're very uncomfortable with vaginal hormones, which, remember, I don't believe there's anyone who totally can't use these things. But if you decide it's not for you, your body, your choice. I'm not here to judge. I'm here to just give information. Hyaluronic acid is a wonderful product that really helps with symptom management. I have not seen a single paper that shows it decreases urinary tract infection risk. The pH data, I'm unclear how much it lowers the pH, but probably a little bit.
So is GSM from aging naturally different from GSM from induced menopause?
Oof, that is a great question. And I don't know that we have data. I will tell you, there are people who are 80 who are not bothered by their symptoms, and we don't quite know why. There are certain people who are much more bothered by their bladder and genital symptoms than other people. I will tell you, induced from a cancer, when it's like tamoxifen and anastrozole, these things can be very harsh to the genital tissues and the bladder tissues, but it's also not everybody. That's the thing. I can't speak in like it is not 100% of people. And so we don't quite know why certain people's bodies figure it out and other people's don't. And that's, and it can be very frustrating when you're in a support group and so is having a great old time with her partner, and you're sitting there being like, I don't even want to be touched because it feels like burning fire.
So let's see. What are the pros and cons of the different delivery methods of vaginal estrogen?
Yeah, so they all work. They're all local. And it's just finding the A, which one your insurance will cover, B, which one you'll actually use, because if it stays in your bathroom drawer, it does not work. This stuff only works when you use it. As soon as you stop using it, the UTIs come back, the bladder symptoms come back. And so you have to, just like moisturize, you can't say, oh, I wore my seatbelt for 35 years. I don't have to wear my seatbelt anymore. You still got to wear your seatbelt. And so you still got to moisturize your face. So it's very important, or sunscreen, you still got to use it. And so it's just, if the creams are messy, the tablet inserts are less messy. I saw that question there. If you have poor finger dexterity and you want the ring every 3 months, that's great. So there's just different products that work for different people. I see the question on lasers, and I just want to speak to that for a minute. There is excitement. There has been excitement around laser there. Oh, we got lasers, guys, lasers, right? So if you resurface a face with lasers, then the collagen grows. So they said, okay, what happens in the vagina? And there's some data to show that you can regenerate vaginal tissue. Now, there are quite a few studies that show some benefit, but large studies, large randomized controlled trials, and they're one that was just published for breast cancer patient, showed that it was no different than placebo. And so it's really important to know, if you're going to spend thousands of dollars on something because you're afraid of vaginal hormones, which you should not be afraid of, right? Then it may not work any better than a placebo pill. And if it does work for you, that's wonderful. I'm not saying it can't work. It definitely could, but there's no data to show that it prevents urinary tract infections. There's none. And so it's really important that we educate women. We don't treat based in fear, right? This idea that, oh, it's better to be safe than sorry. You don't want to touch anything with the word estrogen. It makes no sense. If you have a glass of wine a night, you are increasing your risk of recurrence significantly, right? We know that. And we don't tell women that they can't buy a glass of wine. We don't tell women they can't have a cocktail. And so we make decisions for our body based on good data, but we're not giving women even the choice here.
I also saw in the chat, is adding testosterone okay?
So there are some of us, so DHEA. So I see the question in the chat, in the Q&A, about DHEA and estradiol. We don't typically need them together. We usually use them one or the other. I don't usually need to do both. Sometimes we will add a little topical estrogen testosterone at that vulvar vestibule opening, that if the estrogen's not enough, sometimes that tissue can respond to a little local, very tiny dose testosterone. That's where you get to some expert level care with people like me who do a lot of this in a very high level. But for your general starter, kind of like what everyone can go to their gynecologist, primary care oncologist with, everyone can benefit from vaginal hormones of the ones that I just showed you. I hope that makes sense.
Yes, and I'm seeing this come up quite a bit. Is there a major difference between the estradiol and the Premarin cream?
Oh, it's a great question. So I didn't talk about Premarin specifically, and I'll explain why. Remember I said we've had female Viagra since the 1970s. Well, guess what the first one to the market was? Premarin. Premarin was the first to the market in the 1970s. It is made from pregnant horse urine. It is full of all sorts of chemicals and alcohol. It even has alcohol in it, which can dry and irritate the vulva, but it was the first to the market. So unfortunately, and I apologize on behalf of all medical providers, sometimes we're not good at learning new things, but we have all these other products that are safe, generic, inexpensive, safer, and made of better chemicals or more natural products. So then Premarin. And so does Premarin work? Yeah, it works. Is it my favorite choice? It is my least favorite choice for that reason. We just have better options out there. If it's the only thing your insurance covers, it's the only thing you have access to, it is so much better than anything else that is on the, at the shelves at your grocery store, right? Those things don't actually work and are not tested.
Oof. Is there anything that can be done about the pH level of the vaginal area with diet and supplements?
I wish. There is so many people selling you all sorts of garbage on the internet, and there is no data. Every probiotic in the world sounds great, but there's no data. Nobody can show me a study that says, and if we cared about women, if these companies cared about women, they would do the work. They would raise the money, get the funding, and do the studies to do the work. But they don't do that because you're desperate at 4 a.m. because you can't sleep because of your hot flashes and your vaginal dryness, which is really burning, raw, cutting urinary tract infection symptoms, and you're going to buy anything you see on the internet that tells you it's going to give you relief. So you're going to spend all the money and you just want help because it says it's safe on the box. There's no testing, there's no oversight, there's no one. So it's just very frustrating that these companies get away with all these practices and they don't have to show that it actually does anything.
Ooh.
Sorry, y'all, I get feisty. I get feisty at night. It's 9 o'clock at night where I am.
So, what is a dilator vibration therapy and why is that important?
Yeah, so we love vibration. We love vibration. I can't say that enough. If you can see my birthday present that I got for myself, it's a necklace. It's a clitoris, y'all. It's like it's got sapphire stud at the opening. So we're big on vibration because so the vibration can help bring blood flow. It can bring arousal, which brings blood flow, which brings healing tissues. We love vibration. We love orgasms because it relaxes the pelvic floor. It is so good for your health. And so the more orgasms and pleasure and joy we can have, the better. It's good for your brain. It's good for your body. But if it hurts, if it's painful, if it's not wanted, it's not the right thing. It's not good for you. But sometimes if penetration is something you want as a part of your toolbox, sometimes we will teach patients dilation with dilators to allow for to maintain, especially if you're a radiation therapy, if you've had radiation for cervical cancer, it's really important to use dilators to help maintain that vaginal canal opening. But you want to do it. I love bringing pelvic floor physical therapists because it really does help to relax and train the muscles and having a coach to help you, guide you in that rehab.
So, what are the questions that we should be asking our doctors? Because we can't all come and see you. So how do we know what to say?
So again, that's actually one of the reasons I'm very loud on social media is so that you can come and on our website, rachelrubinmd.com, or our social media, which is at Dr. Rachel Rubin. There are tons of resources, blog posts, videos, written things that I do on vaginal hormones so that we can help. You can go to your doctor with the tools to say, this is what I think is right for me. And they see that I'm not a snake oil salesman, that I have legitimate credentials behind me. And they see the data to say, okay, this actually makes sense. And so a couple questions I see on the chat box. Flaxseed, I put some on my breakfast this morning. There's no data at all for anything to do with vaginal health that I have seen. So if you know something, Dolores, please email me. I'd love to learn more. But nothing that I know of at this point. Questions about Replens. It's another brand of a moisturizer. We love moisturizers. They're great, but they don't fix the problem. They're a Band-Aid, but it doesn't fix the problem. So it's something to consider. Someone saying they're taking tamoxifen because of osteoporosis, but she's getting hot flashes. So again, hot flashes is a whole other conversation. There are many things that we can do to help with hot flashes, but of tamoxifen, it's safe to use vaginal hormones to help with any of the genitourinary syndrome of menopause symptoms. Some people, when they start these hormones, they get a yeast infection because the tissue is acidifying. Treat the yeast infection, keep going, they'll go away. The yeast infections will not be recurrent. They will go away. Occasionally in the first couple days of using the vaginal hormones, some people get breast tenderness and they panic if they still have breasts. Oh my gosh, when I got pregnant for the first time, I had breast tenderness and I wasn't worried about cancer. It was sort of this, my body is like new to this estrogen a rise and it goes away and gets better. So it can be very fearful if somebody with a history of breast cancer. So sometimes we go very low and go slow with these vaginal hormones. And we know that after you get through the first couple hours, those levels drop significantly. And so again, no data to show like recurrence or death or anything like that. You don't need progesterone if you use vaginal hormones, despite what the box says. It is such a small dose. It is safe. If you were on vaginal hormones and you have bleeding, you got to go to your doctor and get worked up to figure out why you have bleeding, right? It's usually not anything serious, but it's something to get checked out.
So what the estrogen cream, like, is this forever? Is this something that's supposed to be done like forever?
I had a patient who came in yesterday. It was so beautiful. She's from a small town. Her husband's a pastor. They came in. She herself is having these horrible bladder symptoms, and she takes care of a 100-year-old woman. And she said, Dr. Rubin, she uses her estrogen cream twice a week after she gets out of the bath. And I was like the happiest person in the history of the planet. My oldest patient was 98. She came in with her daughter who was in her 70s and her granddaughter who was in her 30s. And they came in every time they came to see me, they came all together, and it was the most beautiful thing in the world. And this poor woman couldn't sit, couldn't walk, had no quality of life. We got her on vaginal hormones, and every year I would talk to them for the refills. And she said, my quality of life is so much better. I can just get through the day. I don't have to worry about my bladder all the time. It was just so beautiful.
Just saw there in the chat, is there anything to help with the desire, the libido? And does that help, like, I guess, with that, keeping it moisturized?
Yeah. So if your libido's low because you have pain, then yes, using vaginal hormones will definitely help with your libido. And we saw that in the trials for DHEA. We actually saw a lot of improvement in libido, not because it was helping up here, but because it was helping with the brain arousal connection was really helping. Now, what we do see is there are many treatments for low libido, not many, there are quite a few treatments for low libido. There's a great trial going on right now, Memorial Sloan Kettering, with breast cancer patients, and a medicine called flibanserin, or ADDY, ADDYI. And that's a non-hormonal medicine that is FDA approved for low libido. And the outcomes have been really wonderful. It works in about 60% of people who take it. It works to boost dopamine in your brain. We use things like Wellbutrin. There's another medicine called Vyleesi, which is an injection that you do an hour before you want to want. It's a big hit of dopamine. And so it gets you in the mood, even though you give yourself a shot. It's kind of a crazy thought, but yes, you get in the mood and you get these like wild desires. And so we do have tools. The problem is, in your 10-minute visit with your oncologist or your gynecologist, you're not talking about your libido. They don't want to talk about it. You don't want to talk about it. You're worried about the scan that they're about to show you. Like, it just doesn't come up. But I'm here to say there are some of us who love talking about it, who are good at talking about it, and who genuinely give a crap about your quality of life. And so if you care about it, your doctor should care about it. But sometimes you got to find the right doctor.
Oh, that right doctor, right? That's so, so true. You know, what are some things that we could say, like, to our partners or those who want to start dating, if you don't already have someone? You know, I guess it's like, it feels kind of embarrassing and it's uncomfortable to talk about. How do you know when, like that first time, how do you know when you're ready?
That's where I love the physical therapists, because they're like a coach for your pelvis, right? To rehab your pelvis. That's when dilators, when learning, you know, sort of just, you always want to practice before you go to the big show, right? But you practice before you go to the Olympics. And so if you're going to go on a big date with someone, you don't want to show up and not know what's going to happen. So again, these idea that these are private parts, I can't possibly know. We're going to have to just roll the dice, and this partner is going to know all my buttons, is a ridiculous concept. You don't come with a manual. You certainly don't come with a manual of post-breast cancer. How do I like to be touched? And so you have to explore. You have to learn your new body. And sometimes if that part of your life is important to you, then there's tools, there's things, and there are safe things that you can do confidently to say, I'm going to live.
Ooh. Dr. Rubin, this has
we just went to church, right? We just went to church.
Like, amen. Amazing. Do you have any final words for us before we wrap up?
I know this is complicated, and I know this comes with a lot of emotion, and I know things that I'm saying may be new, may be old. I'm not here to make decisions for you. I'm here to love on you, tell you thank you for caring about yourself, to show up to these kind of lectures, and to think for yourself and decide for yourself what you want to do with your body, with your life, with the years that you have left. And I'm just so sorry that you are suffering with these things. I excuse my language, I fucking hate cancer. I hate it. I'm sorry. I know you could bleep that one out. I hate it for you. I hate it for your families. And I need more funding for women's quality of life issues. I need more funding. I need more research, and I need you to get mad, because you should be mad, because, there are so many things we have figured out and we have helped with, but your quality of life should not have to suffer because of it.
100. Our voices matter. We got to get loud. Well, thank you so much, Dr. Rubin, for this amazingly informative program. And thank you to everyone who came tonight and were lively in the chat and submitted questions.
What a fun group.
Yes. And everyone, please know that the slides and a recording of this presentation will be available on our website at sharecancersupport.org in about 1 to 2 weeks. So don't worry, you will get all this information. We will make sure to send you the social media for Dr. Rubin as well. And you'll also get to see the articles that she was mentioning too. And for Share, make sure that you're checking out our website for upcoming educational programs and support groups, including our annual gala, The Second Helping of Life, being held in New York on September 21st. And don't forget to follow us on social media as well. So everyone, please take a moment to fill out the survey at the end of this webinar. It'll pop up as soon as the webinar ends, and all surveys are anonymous. So this concludes the webinar. We'll see you next time. Thank you. Bye.